Endotracheal Intubation by Senior Clerk Carla Kate Cueva. As a physician expert in intubation, you were called to the ICU for re-intubation of an obese COVID-19 patient who recently self-extubated. The endotracheal tube was noted to be clogged with mucus plug and the oral airway of the patient was filled with secretions. The nurses noted the O2 saturation of the patient decreased from 94% to 85% and became cyanotic and gasping for breath. The patient has the following vital signs: hypotensive at 80/40 mmHg, tachycardic at 110 beats per minute, tachypneic at 25 cycles per minute, and hyperthermic at 39 degrees centigrade. For endotracheal intubation, we will prepare the materials by remembering the mnemonic SALT, PS, and MAIDS. S for suction, A for airway, L for laryngoscope, T for tube, P for plaster, and S for stethoscope. For MAIDS, M for monitor including the cardiac monitor and the pulse oximeter, A for airway including the bag valve mask, IV fluids, drugs, which in this case we will use succinylcholine since the patient is hypotensive, and suction. The next will be the airway assessment of the patient. Since the patient is a COVID-19 positive, a full PPE should be donned. Assessment of airway is then done through the mnemonic lemon. Look externally for any indication of possible difficult intubation, evaluation of the 332, the Malampati scoring, O for any obstruction, and N to assess for neck mobility. Position the patient in a sniffing position. Since the patient is a COVID-19 positive, an intubation box should be used for protection against infection. Since a video laryngoscope is available at the ICU, it should be wrapped with a disposable cover and will be used to optimally view the upper airway of the patient. Prior to induction and pre-oxygenation, we will suction the mucus plug and all secretions. Perform a chin lift or jaw thrust maneuver. For pre-oxygenation, apply a tight-fitting bag valve mask and pre-oxygenate the patient. But while doing pre-oxygenation, the O2 saturation still remained at 90% despite oropharyngeal airway insertion. Patient was difficult to ventilate and no chest rise was noted. What are your next steps to increase the saturation of the patient and provide adequate ventilation? We will reposition the patient in a ramped or head-elevated laryngoscopy position or HELP. This improves the view during direct laryngoscopy so that successful endotracheal intubation can be achieved more rapidly. If the patient is hemodynamically stable, the operating table should be tilted in a reverse Trendelenburg position to decrease pressure on the diaphragm. We will pre-oxygenate the patient again by applying the tight-fitting bag valve mask and pre-oxygenate until the oxygen saturation is 100% and the end tidal oxygen is greater than 90%. After pre-oxygenating the patient, succinylcholine is then given. We can now proceed with the endotracheal intubation. Open the mouth with the right hand and the laryngoscope is held with the left hand and is inserted on the right side of the mouth, pushing the tongue to the left and upwards. The laryngoscope is advanced until the tip of the epiglottis can be seen posterior to the back of the tongue. Advance the tip of the laryngoscope blade into the vallecula between the epiglottis and the tongue. With the handle of the laryngoscope pointing away from you at 45 degrees, lift upwards and away to lift up the tongue and the epiglottis to display the vocal cords and the laryngeal opening. With the right hand, insert the lubricated endotracheal tube from the right side of the mouth directly between the vocal cords and to the trachea until the cuff passes through the vocal cords. Advance every 2 centimeters. While holding the endotracheal tube in place, inflate the cuff with an empty syringe and pull out the stylet from the endotracheal tube. Connect the tube to a bag and confirm correct placement by using the 5-point auscultation method. If upon auscultation there is equal breath sounds, connect the tube to a mechanical ventilator and plaster the tube to the side of the mouth to keep it in place. And we now have our intubated patient. Thank you for watching.